not vaporizer, for the vaporizer filling and for the soda lime, I know most of the time the technicians are the one who do it, but in case you were in the OR, you need to change. Very simple, you do not need to turn off anything. You simply open this, put the medications inside, close it, it will resume automatically. Same with the soda lime. With soda lime, when you open this, automatically there will be a seal.
معلش بدي اقرا بس شوي بعدين برجع بس اقرا بعدين برجع احنا خلصنا بدنا نقرا
مش look doctor
نقرا بس ماشي لهون ماني شايف القراءه
بدي خلصنا
لعلك وين نشوف القراءه very easy. Most people are used to looking at this, right? We have simplified it. You look at here because هلا نحن we did not put it at the gas. You will see the number here change. Look, same thing here changing FiO2.
Okay. This is high flow nasal cannula.
This is high flow nasal cannula and normal auxiliary oxygen. And the way you do it, and normal oxygen.
Okay.
Now the way you use it, you see this small orifice. This is for the normal one, which you've used it. In case you want to use high flow nasal cannula, this orifice needs to be used. What you are missing, my apologies. What you are missing is active humidifier. So you do not have this section right here. There will be an active humidifier. You do not get it to the suction, that's why.
We don't have this one.
You do not get the suction. So anyways, you need to have an active humidifier, then maybe you need to put it on a small table. And this is how you can actually give a high flow nasal cannula. Active humidifier means, same like in the ICU, you put water inside. It is also replicated up here. And the high flow nasal cannula or the normal oxygen, auxiliary oxygen, is independent from the ventilator, meaning you can use the ventilator while this is working at the same time. Okay?
So it can give usually mixing oxygen or only with air.
It can make
or oxygen 100%.
both. So now if it's 100%, this is pure oxygen. If you have a COPD patient, you want 50%, you can make it 50%. Okay, so it's a blender. All right, you can do that. You can do the mixing. All right. Now, soda lime, like I said, when you want to refill it, you can open it and refill it as you'd like. There will be no interruption in the ventilation. This is the most important thing. Okay. I will go more to the technical stuff later on. Here, this is your backup system. Okay. In case there's ever a failure in the electrical gas mixture. Okay, like in your Primus, you have this button here. You have to press it as a backup. For us, you don't need to press anything. This will open on its own, and then you control it here as you like. So rule of thumb, I'll give you an example, because this one you might forget. Today, after 6 years, you're working, you hear teet, you turn, you see alarm. You don't understand what is the alarm, but you see this door open on its own. That means there's a problem. You have to work from here, not from here. Okay, very easy in Mindray. All right. Now, how you operate? Okay, this is your standby screen. If you want to put the patient's demographics to get the ideal, by the way, to fix the settings, very easy from here. Look, you click here, you have all the parameters. So when you put the gender, the height, you get the ideal body weight. Once you get the ideal body weight, if you use also max score, please put the age for it to be fixed. Because if you do not put the age and you look at the MAC, it's automatically on 40 years old. Okay? So now once you press check, what happens? See how the settings changed? Okay? This is how the settings changed. So when you start, this will be your case, right? You're all very familiar. What I did right now, I've configured the machine that when you start the case, automatically it will be on 8 liters. Do you agree? Would you want 6 liters? You want 10 liters? I think 8 is good, right? For induction, 8 is good. Correct? Okay. Now, when you are doing your bagging in the beginning, sometimes you hear a lot of CO2 alarms, low CO2 apnea because of leak, right? Some doctors do not like to hear these alarms, right? So no need to put silence 2 minutes. What you can do here, turn this off. So maybe your technicians can turn it off. So today you can say, while I am masking the patient, I hear TT, tell the technician, please turn it off. What happens when this is turned off? There will be no longer alarms only in induction. When you are doing mechanical ventilation or when you're waking up your patient, do not worry if you forgot this because it will automatically turn on. So today, if I go automatic, your alarms is normal. Today, I want to wake up the patient on manual. automatically turned on. Understood? Okay? So this is for people who do not like to hear a lot of alarms during induction. Okay? حسب اللي بيناسبكم. Now, you have definitely the CO2, the peak pressures, the volume. Here is, you're very familiar. You can click on the total flow. You can go down here, go up. You can put the measurements as you want. One, press check here or press check there. Or you can play around from this one. What I did new for you is that when you click on the flow, after induction, look what I did for you. I did for you shortcuts. 1 liter, 50%, 2 liters, 50%. So meaning today, let's start again the case. This will be your default settings. I started 8 liters. I'm masking the patient. Induction, you give IV, or you want SIVO, for example. So you click here, SIVO. You change like this, change like that. If pediatric, you can click on the number, automatically it changes. It makes it higher, right? So pediatric will give higher, all right? So I'm gonna put small volume right now, okay? Once you are bagging the patient, pre-oxygenation, then you have the flow pause like you told me, doctor. So for the technician, in case you don't want to stop the gases manually, you can press flow pause. When you press flow pause, automatically everything stops. So there will be no volatile agents in the room, okay? When the time finishes, it will start automatically. If you are very good, you will intubate less than 10 seconds. Most of you guys are very good, I believe. Automatically, your nurses, the technician can press end, you're good to go, right? So now we have the tube, you go to automatic, correct? Automatic, you will have here the picture change. The green represents the volume it is giving. Today, if you have a leak, for example, the leak will show you here. But what if my screen is like this and you're working with the patient like that? You can look here. Here it will show you leak and disconnect. So remember, whenever there's a leak, whenever disconnect, this screen will also show you from here. Okay? Now when we are automatic, I put for you the volume control as the main mode. What I put differently is PEEP 5. Because here PEEP 0 means PEEP 0. And I think 5 is good as standard. Right? Now we will go down to low flow. Instead of you
Doctor,
changing like this,
we are in the demo mode, so there is no issue.
there's
No
no air.
alarm?
Yeah, no alarm, because we are in the demo mode, doctor.
No air, no gas.
I
No
would have
gas.
to check the alarm.
No, this is in the demo mode,
It's
doctor.
demo mode. You can
I did
see
not
here.
put any
Yeah.
gas.
We can check later on if you want. It takes 2 breaths, more or less. Depends if the disconnect is from the patient or if the disconnect is from here. But at least 2 breaths. So you want to reduce your flow. What you can do, like I taught you right now, you can click here or click here. Look, press 1 liters, automatically change 1 to 5. So much faster. Okay, no need to change both. Now, how do you do your flow? You see, there's 2 ways. You can do the basic way, which I presume most of the people is using, or you can make the automation, which I will teach you with the automation later on. Basic is what? You have this green. This green is an indicator that tells you what is the lowest and safest fresh gas flow. يعني out أو أأمن fresh gas flow حسب شو depending on what? Depending on the patient. Meaning if there's a system leak, there's a high increase in patient uptake, it will change. Okay? Now, because you have the best machine, honestly speaking, I will not recommend you to use the basic. It is for example, you have a car, you're driving the highway, you can press benzene, the gas all the time, but you have cruise control. Why not use cruise control, right? So what is our cruise control? Look, click here, ACA. ACA is this automation. Has anyone used it? I don't think so. So let me teach you now what it is. You click on ACA. ACA means automatic control of anesthesia. You anesthesiologists have a target in your head. You play with the fresh gas flow and the settings as you would like, right? Here is different. Here, like cruise control, you put the target. Look, target FiO2. Click here. Let's say I want the target on the patient 50%. So I will put now 50%. Now I want to put the target of end-tidal sevoflurane, maybe 2. Look, 2. And if I put 2, look, my MAC is also appearing up. So for this patient who is 55 years old, I think, no, 40, see, I did not put here, for 40, 2%, not 2%, 2% of end-tidal sevoflurane is MAC 0.9. What I do, confirm, look at the layout, how it changes now. Okay, so what does this mean right now? It means today your target is 2, meaning the machine will do whatever it takes to always reach here 2. Forget about these numbers are fake now, it's demo. Okay, now Your oxygen target is 50%, meaning the computer will always here be FiO2 50%. Your end tidal is 2. Okay? Now the question will be is, what is the settings of sevoflurane? You will not know. The machine will control everything, number one. Number two, what is equally important is how much is the total flow. This is the very important thing for you guys. You will look here. Oxygen plus air, you combine them, now it is around 6 liters. Okay? So you know, for example, today, if this is a real patient, 0.2 is very far from 2. Like today, I'm driving 20 kilometers, but I put cruise control 100. What happens to the car? بيقلع, right? يهيبس البنزين. He's going to press it to reach as fast as possible. What you usually do manually is increase the flow. The machine will do it for you. Once it reaches 2, what happens? It will slow down. ذاك الطريقة بخفف البنزين. I will maintain 2. What happens later on? It will start to slow down the total flow to what? 0.3. This machine can do complete closed metabolic flow. Okay? So, how you know 0.3? Look here, minimum. Minimum means 0.3. Now, it doesn't mean the computer will always go down to 0.3. Okay? It's you are telling the computer لأنه بتحدده, right? The maximum is 6 liters as per the protocol. The minimum is 0.3. If there is no system leak, very low consumption for the patient, it will go to 0.3. And most of the time I've seen 0.3. But if there's a leak, what happens? You have to increase. Here, don't care, machine will increase for you. Now, some doctors will say, Wallah Hadi, I don't care about 0.3, I don't want 0.3, I'm very uncomfortable, خاف. Fair enough. You can tell the computer, ممنوع تنزل تحت 1 liter. You're not allowed to go down less than 1. Very simple, look. You click here, minimum, put 1. So now you tell the computer, the lowest you can go is 1. It means what? Lowest one to reach these targets. Okay? Is it very clear? So usually in the maintenance, this is so good because you don't need to anymore worry about increased flow, increased whatever the volatile agents, right? You have hypotension. What do? You usually decrease the settings, right, of the machines. Here you decrease the target to 1.6, for example. Remember, these are targets of the patient side, not the machine. Is it clear? Now, the next thing is what? How do you wake up the patient? What you usually do is turn off Sevo, increase the flow, right? Here, very easy. Look, something called purge. You click on the Sevo, you have something called purge. When you press purge, the machine will shut down Sevo, flush the system in 10 liters. So you click this, automatically, you see it will be 10 liters. Look here. If you want 100%, you have to increase this to 100 because it will stay to the previous settings. Okay? And then you have Sevo turned off. Then you will see here within 20 seconds, your Fi sevoflurane will be most likely 0. Okay? Is it clear? So we will start this again.
And the flow is not showing anything, any change.
It will not show you down there, doctor, but where you will see it, it's a good question, you will see it here. You see? It's showing here.
10 liters.
Okay, so I will give you now an example of the workflow. Okay? Then we will conclude everything. So I started my case. Today I'm the anesthesiologist or the technician. First, what you do, click here, put the category. As you know, I'll put my weight, and the height. I have my ideal body weight. I care about the age because I like to look at max score. Let's say I'm an 88 years old man. I'll start, okay? Prepare my mask. No need to put here 8 liters. I already have this as an 8 liters with the settings of 5. So what I do, this will be manual, right? Start case. You mask the patient. Maybe I am a patient, I'm a doctor, I don't like to hear beep, beep, beep all the time. Turn off. Turn off. Okay? I want to give Sevo, click here, increase Sevo. Your target's reach after 3 minutes, or you give the Nimbex, for example. You have a timer here, or later on I'll put for you a timer there. So both, depending on what you want. Most doctors I meet, they like it on a big monitor because the number is bigger. Okay? Or you can use both. One for the time of the surgery, one is for the neuromuscular. So how you start it, you click here, look, start, very simple. Okay, so you decide the timer. Anyways, I'm getting ready to do the intubation. I don't want to inhale the gas. I or the technician, click, slow pause. Put the tube, everything good, finished already very fast. Put unpause. secure the airway, put automatic, right? Once I'm automatic, these are the modes. If you want to change, very simple, let's say 650. Okay, one thing I forgot to tell you is when you put the ideal body weight, our machine can show you the ml per indicator. Look here. How much volume per ideal body weight. So when you talk about lung protective strategy, you have this number. Meaning, today if I have a high CO2, if you increase the volume, look now, it will tell you how much cc, how much ml. Maybe it's too high, let me change the rate. You see how? So we have this indicator. This indicator will only show you if you have the ideal body weight. That comes from the gender and the height. Okay? So next I want to go to low flow. Two ways. You want the basic, you can click here, go 2 liters for example. See 2 liters 50, you can change as you would like. I would encourage you to use the cruise control. So what you do is click here, ACA. I want the target, for example, 60% on my patient side always. I want the SIVO, for example, MAC to 1.4. You see up, which is equivalent to 2.2 for an 88-year-old person. Confirm, confirm, khalas. What happens right now? Forget about this. This is a warning because it's high. And then the machine will go as fast as possible to hit this and hit this target. Once it's reached, later on, keep your eyes here. This one you will see later on slowly go down to 0.3. Okay? And I will repeat. If I don't want 0.3, I want 0.5. Click here, 0.5. If I want 0.3, which is the lowest, you can click here, you press minimum, it already is 0.3. Is it clear? Very simple. This is throughout your maintenance phase. When you want to wake up the patient, 2 ways. Either you click the SIVO, put purge, khalas, completely close. That's one technique, which is the fastest one. What if you want to make it slowly? Right? Some doctors like to say, you know what, I keep low flow, but I turn off the SIVO. What do? Here you cannot control the flow, right? No problem. Click this, turn this off. When you turn this off, no more SIVO, because no more target, but it will stay in low flow. Meaning here you have 10 to 15 minutes, for example. But if you want to rush it, then khalas, you click here, go purge, purge it. If you feel uncomfortable, you want to go to the old way, you can, look, click here, go to total flow. Total flow is, press check, is what you are used to. There's 2 ways, but honestly speaking, if you are ACA, and then you click to change total flow, and then increase the flow, close the SIVO, khalas, very easy, just click here, go purge, you see, 2 buttons, confirm, automatically. SIVO is closed, flush the system by 10. And you might tell me, Hadi, well maybe I want more than 10. Look, click here, you can put 12, you can put 15, as you'd like. Most of the cases I've seen 10 is more than enough. Because 10 with 20 seconds, really, the FI sevoflurane is flushed out from the system at least. Okay? Then in the end, what do you do? Khalas, very simple. End case. Voila. That's it. Any questions with the machine? Right? I hope you learned something new. Alright, very straightforward. There are more advanced things, but I don't know how many surgeries you do. I would say I'm coming back maybe next time in maybe December. Maybe I can teach you guys later on the lung recruitment. Or if you want to learn now, I can teach you lung recruitment. Would you like?
We know it.
You know it. Very, very, very good. Let me see what indicators you have here. So, very good. So, what if today I'm a doctor who wants to look at more advanced parameters, more detail? I have a very long case, right? So this is normal layout. What you can do is you can click here, and then you can activate the first 4 down there, which is very important. So let me show you. 1, 2, 3, 4. You have spirometer, volume, mechanical values, and the compliance trend. And I'll explain to you one by one how you can use it. Okay? So now here you have the PV loop. Alright? Very small. What you can do, click on it, boom. This now will appear. Let me show you, see? Okay? Now, you can read the graphs as it is. I think it's very straightforward. But how you can utilize this function? Usually, as you know, as an anesthesiologist, before you extubate, it's always best to keep the lungs how they were, right? If my lungs are open, my compliance is 60. Throughout the GA, maybe my compliance goes down to 30, whatever. And if you extubate me on 30, the risk of pulmonary complication will increase, right? But how do you know the baseline? Very simple. You take a picture. Look. Save loop. You wait a little bit. Show reference. Now look, baseline. You see the white one? The white one is the baseline right now. Okay, so when you usually intubate your patient, this is where you want to nicely take the snapshot of the patient, right? Okay. Now this is very good for long cases. Short cases, it's very, you know, it's not nothing significant. But if you talk about 4 or 5 hours, the longer the case, the more chances of atelectasis, right? This is where it's very good. So you have one indicator for you to know if you want to do lung recruitment. And usually the PV loop will go down like this. This is where you lose compliance, okay? That's number one. Number two is, you have here the delta VT. Delta VT is the difference between inspiratory and expiratory. So this is a nice indicator if there's a leak. Now, one nice thing about our machine is it will tell you there's a leak, but it will compensate. Okay, this is something very, very nice. So sometimes you look at VTE and you will look at VTI. Sometimes you will feel they're not the same, you will feel they're the same, but you will see the delta VT is 100 ml. You will think, how come there's 100 ml yet VTI, VTE is the same? It's because inside the machine, our sensors can compensate. This is something Drake and other machine cannot do. Okay? So this is one nice thing. Next is you have here. Here you have straightforward, you have the compliance, you have the resistance, which is very simple, you know the lung mechanics. To be a little bit more advanced, if you want, is the P drive and the mechanical power. These two, the first and the last one, this is comprehensive way of looking into lungs. What do I mean by that? There's a lot of new studies right now, okay, for the past 8 years, that these two values are linked to more mortality rate and higher pulmonary complications. Think of these two as a parameter that shows the infliction or the damage onto the lung. Mechanical stress onto the lungs. For other words, the example is like, I am punching the lung. The more you punch the lung, the higher the damage is, right? Because positive pressure is good, too much is bad, right? So instead of only looking at peak pressure and looking at the compliance, which you do day to day to know the wada al-marid, if it's good or bad, these two are more comprehensive way. And I can share with you studies later on. The threshold, and the limit, is above 15 is not so good, it's linked to mortality rate. Above 17 here is also linked to mortality rate. Now the question would be, you tell me, Halit, if it's very high, what do I do? Two things. First, it depends how high it is and how long. Today, if I punch the wall 1 time, nothing will happen. I punch it 200 times, it will be something, yeah? Right? My hand will break or the wall will break, right? So long surgeries, actually, this is very important. This will show you if you need to open up the lungs or not. And when I say open up the lungs, I mean lung recruitment. Other than that, everyone talks about lung recruitment, but you don't have indicators other than the compliance and the peak pressure. Now you have more of a comprehensive way of looking at it, which is linked to clinical studies. This is the most important thing. So what will you do? You know, today if the compliance is low, very bad, you need high pressure to put the volume inside, right? Monte Ian, it's the concept. So what you do, you need to open up the lungs. What you can is increase speed or do lung recruitment. When you do that, these pressures will start to drop. You understand? Because driving pressure is what? It's plateau pressure, difference between plateau pressure and peak, which is the volume that has been given, right? 15, if you think 15 for an obese patient is very low. But if the obese patient, the lungs is opened because of good PEEP, good lung recruitment, wallah sarah, you don't need more than 15. All right, this is the principle. Okay, and then you have here the one step and the multi-step. You can ignore the inspiratory expiratory mode because this is very ICU. One step I would say is nice for like how you do the manual in your hand, or I don't know if you do thoracotomies and thyroid surgeries when you want to do the Valsalva maneuver. When sometimes you do this and that. Actually, wallah, you don't need to do all this. Why? You put procedure, one step, you put the pressure that you want. For example, I want 25. I want to put it 10 seconds. Let's press start. Sorry. 25, 10, press start. The machine will do 25 for 10 seconds. Once it finishes, what happens? It will turn back. Okay? You want to stop it? You press this, it will stop it automatically. Oh, sorry. You will press, where is it?
The red one.
Yeah, actually I stopped it. Yeah, when I pressed the red one, it stopped. In case they say, khalas, it's enough, good to go.
Yes.
All right? And multi-step, you can control everything. What I will do, because had the waj'a ras, this is to fill it in. I'll make an example, save it as a profile, Okay, and then you can actually start to fix it or to adjust it accordingly. Okay, what I usually do is like this, because the best technique is going up slowly, going down slowly. So let me change it for you. So I put the driving pressure 15 to be fixed. I will increase the PEEP in 2. So I will start with 5, 7, 9, 11. Okay, little daraj, like a stairs. Then I go downwards. 9, 7, 5. I will save this procedure as PEEP 5 plus 2. So you guys can remember. Please 5 plus 2. Confirmed. Created. So what happens right now? I give a pressure of 15 over PEEP of 5. How many times? 3 times. How long? You have the IE ratio and TI from these two. This total step, 15 seconds. After 15 seconds of 3 breaths, it will jump PEEP 5 to 7 alone. Then it will go up, 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 then go down, down, down. How do you do? Press start. Then you see it will do all this on its own. Now what do I mean by that? So look now, you have here real time. You have pre-recruitment in the very, very beginning, and then you have variance. Variance who will find the difference. Okay? The best way is to check if I really open up the line, I succeeded, is you look at PEEP 5 before recruitment and PEEP 5 after recruitment. So when this is all done, when you come here, you will check here the difference. Did I gain PEEP? Did I gain volume? Did I gain compliance? If yes, you know that you were successful. And then some doctors, maybe they will say, because I was successful, I will put PEEP plus 2, meaning my baseline PEEP is 7, to keep it open. Right? The problem is how you can open it. Can I open it, yes or no? Can I keep it open? This is another question. So some doctors like to put an extra PEEP. Okay, and in case the patient did hypotension, you can press stop in the middle. Otherwise, you will see here, look, these are the differences. Okay? I know it's a lot.
Yeah. Shall I make the PEEP, our PEEP, 0 or don't do it?
I would recommend you always to put 5, Sarahatan. PEEP 0, unless, yeah.
I mean, during this procedure, I know.
Very good. In this procedure, no, you don't need to. Because 2 things I want to tell you. Once this recruitment is done, inshallah, يكون multi-step or single step, it will go back to its previous settings. Okay? Now, let's say, for example, you tell me, Hadi, I don't like your protocol. I want to change. Right? So what you do is, here you can click 7 and you change. But why I put 5? Because most of the time, most of the patients will start at 5. If you have an obese patient and he started with 7, then I would recommend you start at 7, actually. So you can change all that accordingly. All right? Now, this is very, let's just say, unique. Not every day you will use it, but I highly encourage you to use this every day. ACA. ACA, automatic control anesthesia. يعني كيف عندكم TCI, target control infusion, it's same target control anesthesia, TCA. Okay, now moving to any questions? I hope it's clear.
So during this recruitment, shall I make the oxygen 100% or only?
Depends. It's up to you. It's up to you. Some doctors, I've seen them, they do it. Okay, some doctors, they say, no, it's fine because why? I'm just increasing the pressures. And usually when the PEEP is increasing, somehow the compliance should be improved and you have better oxygenation. Keep in mind, this is just temporarily. Okay, but one important thing is why I wouldn't say you need to change because انت مثبت volume here. That's why I insist to put 15, 15, 15 or 12, 12, 12 or whatever it is. If today you give different pressure support or pressure or delta P, you have different volumes. When you have different volumes, then I would say your assessment is not very accurate, I would say, right? When you want to do an assessment, that's why I said it must be from the start of the PEEP and end of the PEEP must be the same. Volume must be all the same to really to know if I just stuffed it or not. Okay, if I improved or not. Now we go to the monitor. A few things I want to explain to you also here. What if today you have a local anesthesia, right? I don't know if you do regional here, and you want to monitor just the CO2. Right? So what you have here in manual mode, you have here monitor mode. You can click on monitor mode. What is monitor mode? Monitor mode means no ventilation, only CO2 is working. Now the question is, will you tell me how can I measure the CO2? The sample line here. The sample line, you put it here next to the patient. Okay? Now, but keep in mind, because there's a lot of leak here, the CO2 reading is not going to be very high, right? You are checking only if the patient is breathing. So what I will recommend during this scenario is turn off the CO2 alarm. Otherwise, you'll hear beep, 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 beep,
Yeah,
beep, beep.
because
all
it is
the time.
not accurate.
It's not accurate, exactly, because there's leak. You're using this only to see if there's chest rise. Okay, so this is one thing I would say you can actually do it. And then you can press end case, and then as it is. Okay, clear? All right. Technicians, any technicians here? You? Very good. So the vaporizer and the soda lime can be refilled both during the case without any changing anything. Meaning you don't have to turn the SIBO off. You just open, refill. When you open this, automatically it will stop. You refill, close, good to go. Number one. Number two is here, you open it, refill, automatically there's a seal. Don't need to worry. Okay? Now, if you have babies who you want to do a maple C, meaning T-piece, this is how you do it. Okay? Very good. Now, there's one trick you probably have noticed, is that on the standby you cannot use it.
Yes.
You have to start the case,
Then
turn this on, and when you want to stop the machine, you have to turn this off and then end case.
yeah.
Okay, otherwise you're not going. This is for safety reasons. Okay, this is something what you need to know. How do you know you're in this mode? Look, when you turn this on, ACGO is here. ACGO also will be here. So let me show you in actual case. So look, ACGO, ACGO, ACGO. Okay, clear. So now we will go to the monitor. Monitor, what I plan today is I can change any settings that you want, meaning the colors. I believe maybe non-invasive blood pressure, you like it red, correct? Or you're used to white, red. I will make it red for you, that's number one. Number two is, what I've seen is you have this cable. Is it true that all the rooms it's red cable?
No, it's gray.
It's gray, so very good. That cable is very good for the cautery. This is eliminates artifacts, which is very good. Okay, so your ECG is more precise. What is bad about this? You cannot get the respiratory rate. Meaning today, if you want to do local anesthesia and you want to see the respiratory rate from the ECG, this cannot calculate. You have to put the brown one, the gray one. Okay, it's not Mindray. It's all machines that have something called ESU. So it's called electrical, surgical, I don't know what for the artifacts. Okay, so that is one. And let me just open a demo, give you some data, so we can play around with it. Then I'll talk about this and NMT, which is the most important few things for you guys. Okay, then we'll go to the configuration. Now, let's say today the QRS, the TT sound, too low. I want to increase it. Very simple. Click here. Go to volume, click this, increase QRS code, QRS volume, okay? I will turn these off, just so we can talk to each other better. Okay, let me now also fix this, so I can teach you a few things. And what I plan with the engineer is I will finish the configuration, copy paste it in all your machines for it to be all looking the same. Okay?
Yes.
So just give me a moment. What do I want to do? Okay, now there's so much data here. This is not usually the case, right? Because the more data you have, the smaller the numbers, because it's 15-inch, right? One nice thing about Mindray, you notice, if I put ECG, ECG will show. I take out ECG, will not show. Same with temperature, okay? So, like any machines, when you need to change anything from the monitor, you simply click here. Okay, you will have the alarm setups, the changes, etc., etc. I think this one everyone is familiar with it, right? From the nurses, from the doctors. Most importantly, the NIBP, if you want to change, most people what they do is they click on NIBP and they change the interval from here. That's correct. There's a faster way. Here, look. NIBP measure, you click this, you have all the, what do you call it, the selections, okay? Now, NMT and BIS are, let's just say, a little bit more advanced. Some people do not know how to put them. It's okay, no problem. So you will click here on NMT, for example. Every vital sign has an introduction. So you click on introduction, shows you a picture. So how do you put it? I saw earlier the NMT.
Yeah,
Have you used the NMT?
This one.
Yes. Have you used it before?
No.
No?
Yes.
Very good. Now it's time you can use it. So very simple. Yellow with yellow. So you will place it right here. Okay. So it's placed on this section right here. There's a yellow section right here. Okay. In case you don't know, it's written NMT.
Yeah.
And you have a picture right here, exactly the same thing. Okay. So I will bring it in. Now the question is, the most important is how you apply it onto the patient side, okay? So you have two electrodes. One of the common question is, how do I know is the red distal or proximal?
Is it written here?
Bravo, yes, very good. You see, written here, not only that, doctor, look.
Okay.
Okay, very simple. So you bring any ECG electrode, keep in mind, you put them here. Now maybe you don't know the exact location, it's also shown to you. It is actually towards the ulnar. Inside, and then you have a few centimeters. Sometimes the people put it on the bone section, it can read, not so accurate. It should be on the ulnar side. Okay, that's number one. Number two is this thing right here. This is a disposable. Maybe you will not use disposable. It's not necessarily why. This is the sensor, which is most important. Let's say today you don't have this. What do you do? Normal plaster, very good. How you put it? You see here? There's a flat surface, so it's like this. Not like that, like that. Any plaster you put it, you're good to go. Okay? Now, a few things you need to take note. After you apply it, and the machine reads that there is electrical activity, what you will do is, you will click on the NMT. Sorry, the screen is small because there's so many things. Okay, you click on the NMT, you will get this calibrate activated. Usually when there's no ECG electrode here, this one you cannot click it. Okay? What you should do is you should press calibrate in the beginning, which is the best thing. If you put directly start, it doesn't take the reference sign. Now when you press calibrate is after few seconds before you give the neuromuscular, or as soon as you give it to the patient. But definitely, as you know, because you already gave the propofol, the Fanta, and then it's already in effect, so he will not feel the pain, because he or she, if awake, he will feel pain. All right? Now, if the standard for adult is 60, but if you have pediatric, which I will save it for you, but this is just for you good to know, sometimes pediatric, you have to make it lower. 60 is too much. You will click here, you will go to usually 30 is enough. Okay? You see, it will change the results, whatever it is. So remember, measure, set up, check the voltage. Adult 60 is fine, pediatric is 30. Okay? But I will make it as a default settings for you. But you guys as experts, you definitely have to double check. Maybe I made a mistake, maybe someone played around with it, you never know. Okay? Now, after you put everything, you will put calibrate. You press OK. The machine will do the calibration. You will hear teet, 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 teet. Take the measurement, it will do another teet, 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 teet. Okay, then you press cancel, you will get the measurements from here. Okay, how the measurements will look like this. I hope it works on the demo mode. When this is finished, I think you get, yes, you got the measurement. All right, now what I did, please please note, I press start. Don't press start, press calibrate. The first time is always calibrate. So I will tell you, when you do the calibrate, it will do one shot. You will hear teet, 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 teet. Then it will do another TTT. The first TTT is a reference, okay, which you will get this. And then the second one is the actual measurement from here. Okay, now what are the measurements? It's like any NMT. I'll explain to you a little bit. You will see two phases. Number one is you will see here percent. Then you will see something called count. What does it mean? When the patient is fully, not to say recovered, in the beginning normal, it will start to do the percentage. What does it mean? The percentage is it will look at T1 versus T4 and see the difference. It will give it by percentage. Okay? Once everything has dropped, okay, it will no longer see there's any more, let's just say, strength in the current. It will count how many times the hand moved, not the strength of the movement. So here you will have it as count. It will go 4, 3, 2, 1, and 0. In the TOF, it's always giving 4 pulses. Pop, 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 pop. You hear like t, 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 t. Okay? So, percent is 100% all the way to 0. After 0, it goes from 4 to 0. The lower it is, the more the patient is blocked. So just remember, when you have counts, you will see this in blue. I wish I could replicate for you. You will see it in blue. Blue means you're actually no longer looking at the strength. It's how many times the machine detects it. Okay? The same thing with recovery. When you want to recover your patient, it goes upwards. So count becomes 0, 1, 2, 3, 4, meaning it can detect 4 movement. When it detects 4 movement, it will start to look at what? The strength between the 4 and the 1, which is a percentage. Okay? Is it clear? Now please remember, I need to highlight this thing, is that as you know, the diaphragm restores faster than the hand. So you will see here the ETCO2. This is mostly for the, I think, surgeons in the end of the day. Okay? Now, in case you want to go a little bit deeper, and you have a very complicated surgeries, and you want to look at deep block, you have something called PTC. Sorry. Post-titanic count. Post-titanic count is 20 pulses. So same concept. TOF is 4 pulse. PTC is 20 pulse. How they usually use it is after TOF goes from 100 to 0, then 4 to 0 in counts. This is medium block level. You want to go more in deep block, you look at post-titanic count, you click here, it will do ta 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 20 times, and then you will see the numbers. The higher the number, the more response is. The lower the number is, means the more the patient is blocked. Okay? This is just few for you to know. Extra is intervals. You can have it 1 minute during the induction, or after the recovery you can make, or after the maintenance you can put 15 minutes. Please remember that when you want to wake up the patient or when you give the reversal, press stop. So when I press start, and then you have to press stop later on. This is one thing I notice many people forget. Why? Because when the patient wakes up, there's no more medication. If the NMT is still there, you will hurt him in the end of the day. Okay? This is for...
To differentiate between depolarizing and the non-depolarizing muscle.
Very good. Okay. How it looks. So you know that, I forgot, I always keep on forgetting between depolarization and the non-depolarization. The medication, I forgot, that does this.
Succinate.
Yes, exactly. You will not have T1 to T4. 4 of them goes down to the same.
Sustained release.
Exactly. So what happens is that the percentage is useless. When everything goes down, and then you look at the count. Okay. You will look at the count. When the count goes down to 0, that means really the patient خلاص راح يعني blocked.
But if only 1 contraction, it means it is succinate fully. If 4 contraction,
no, it's always you. No, I wouldn't explain it like this, doctor. لأنه يعني the one that the transmitters when it goes downwards like a stairs. Okay, this is not the non-depolarization drugs.
Yeah, sustained contraction or sustained release.
Yes.
And the problem sometimes we give the patient succinate fully, then immediately without wait we give non-depolarizing.
What about?
Exactly. So at the end of the case, sometimes it is a problem of succinate fully, not a problem of non-depolarizing whatever Nimbix or whatever. So differentiate between both of them.
If you see it going up slowly, it will be.
ما بديش تستيب اب دي.
ما في stop.
This is what even when we are using the nerve stimulator, old fashion, if it is only 1 contraction, it is succinate.
Correct, because أربعتهم بيكونوا مثل بعض.
Exactly. If like this, like ladder or
which is Nimbix.
This is Nimbix.
Yes, correct. Then yes, then I agree.
Non-depolarizing muscle.
Yes, then I agree. I agree with that. Okay, so this is for NMT. Now BIS is very, very straightforward. BIS is here. You click on BIS. After you attach the accessories, one of the biggest problems, you have it here. Okay, it's expensive. But I don't know. صراحة بالسوق السعودية
But it was around.
But I will tell you one thing. The most important thing, or the common mistakes that I've seen, is that people forget to clean the forehead. You have oil sometimes, right? So always wipe it with alcohol, wait for it to dry, and then put it. But if you do not do it, will it work? It will work sometimes, but sometimes you will have poor signaling, okay? But how can you know if the sensor is working properly? Is that when you click on this, look at check, sensor check. When you do the sensor check, it will check all this. When everything is green, خلاص, it's good. Now, how do you know also if it's very good? You will see it from here, from the signal. You see, SQI is Signal Quality Index. If the quality is bad, in both ways, it will write for you here poor signal, artifacts, etc., etc. Okay? And then you have the alarms here, which is straightforward. You know, the 40 between 60, you can change the alarm. Now, you might tell me, I do not want to see the EEG. Maybe I just want to see the trend. So you can click here, you go to setup, you can decide what you want to look at. Display, for example. You might want to see just the trend of, for example, the BIS trend here. What happens? So you have the BIS here throughout the whole, for example, 1 hour. You see here, am I staying between 40 to 60 or I have this gradual drop, gradual increase? Okay? Now, most doctors I've seen, they like to see the EEG. But anyways, you have all the options later on. You explore and see what you would like. Any questions you can tell me later. You can ask. You can make it 60 is only the biggest one. Okay, this is for the. This is for the BIS, and then the consumable is very straightforward. This is the connector over there, being hot over there, and then you have a clip here. Usually, they like to put the clip there. Okay, in that sense. Now, a few extra things before I go to invasive. I've added for you here resource mode. This resource mode is in case you have a cardiac arrest, okay? All the time you hear beep, 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 beep. Very annoying, you cannot communicate. You press silence every 2 minutes, right? Very annoying, no need. You click resource mode, what happens? It will enter a resuscitation mode, meaning all the alarms will be turned off. Only the important information, you see? No need for CBP because our father, it's useless. No need for BIS, right? Only the important things will appear in front of you. Patient, inshallah, he goes back to ROS. You press exit, goes back to normal. And this is a nice thing. So you want to permanently silence during the resuscitation mode, just to communicate properly, you can click on this. Okay? Now, if you have a regional or local surgery, maybe you don't want to see numbers, you like big numbers, you don't want to see a lot of data and small data, so you can use 2 fingers, swipe like this. Maybe this is something I've seen people like, big numbers, basic numbers, right? You don't need advanced stuff. And the way you go back is the same, swipe like that. Okay? In case you want to discharge a patient, which I highly recommend you to discharge a patient because the file will be retained or organized better, 2 fingers up like this and press discharge. Okay? Why? Because in the future, you are writing documentation with your hands. Inshallah, soon it will do the EMR. Okay, I already spoke, I was in Dammam yesterday for the branch. They're fixing the security problem. There was some kind of security problem. Once it's done, then our machine can send to your local EMR or the HIS. But in the meantime, if you want to review your patient, very simple. Press menu. You go to discharge patient. You have all the data over there. Nothing's deleted, like a mobile phone. 4 gigabytes of storage. You click this, for example, and then you have everything. Tabular, graphical, events, blah, blah, blah. And it's the same thing when you want to document it with your hands. You have the, review button. You have all the data right here. Okay? Now, what if you want to look at graphical? No need to do all this. What you can do from the computer, look here. You have all this. So today, if you have hypotension or hypertension, it will also highlight for you here. Any alarms, for example, I'm your technician, doctor, right? You want to have a break for 1 hour, okay? You want to come back. You want to see what's happening, right? You can see definitely from here, from these parameters, or you can swipe here, all the alarms that happen, all the data is from here, and then you can make it even bigger. You play around with it, explore with this is some few things. Now, we will go to the arterial line and CVP, okay? Arterial line, the most important thing is you have to do zeroing. CVP, you cannot get a measurement before it does zeroing for you. It will tell you zeroing required, and I think arterial line also, if I'm not mistaken. How do you do it? There's three-way stopcock.
Yes.
You know very good.
Yes.
Look, click zero here. You can zero all, meaning let's say today I'm a patient with arterial line and CVP. You don't need to put arterial line, CVP 0. Halas, you press zero all. Both of them, you turn them, open them to the atmospheric pressure. You press zero all, it does 2, then you close it. What if you want to do only 1? You press this. It will do the zeroing. You're good to go. Okay? Is it clear? Now, let's say today, this was PA, pulmonary artery pressure, PAP, not CVP. Okay? Because the measurement is very close, right? What you do is you click here, set up, very good doctor, exactly. See label, click here, change to whatever label it is. Because the measurement pressure is actual pressure. Labeling, you just have to label it and that's it. Alright, and the way you do it, okay. Now we have multiple different types of connectors. From the patient side, from the monitor side, this is the same. Here, I don't have to be very honest. I don't know what you're using. This looks like an ICU medical, if I'm not mistaken. And you have yeah, very good. You see, you connect it like this. No, not this.
No, this one.
So this is another version.
This is for what?
Another type of this one, doctor.
Another type.
Another time.
Yeah, this is like a square with black. I think it's called BD, if I'm not mistaken. So anyways, you see, that one, that patient side, to this one, you connect it, and then that's it. Then everything is same. You need to inflate the bag, okay? The transducer, which is a sensor for the pressure,
Yeah, of course.
which is taken from this section. That's what I'm saying. Sometimes they sell you only this.
Yes.
And then you put a normal Lurlock, a normal IV, it can, but here, there's no way to actually read the pressure without this.
Of course.
Yes.
Okay?
Of course, this is
Especially if the patient in ICU and the continuous reading, it will be very, very
So اللي هيكون انتو ل CVP, you need to check the consumable, يعني what
It
you.
will be matched with our transducer.
Well, we can change the transducer. To be honest with the engineer, as you see, we have different types of transducer.
Yes, yeah.
Okay. Once you decide on the consumable you want, the brand you want, okay, then you can contact us, and then we will tell you which cable. Maybe this cable can work.
Yes.
Maybe another cable. You need to maybe give another cable. وفي شركات مثلا بيبيعوا على السي في بي بيقول لك انا هون ببيع لك الوسط section, and then you have the metallic section. The metal is on the skin. The white is the outside area, and then you have to put it more to the core area. If you put it on the shoulder, it will not give a very good reading. It will give you 33 in the end. But in the OR, I agree, esophageal is the best one in the end of the day. جربوا حاسكم, maybe, I don't know, ask the management. منه كتير غالي يعني صراحة. Maybe at least I would say get 1 or 2. Since you have special cases, just get 1 and 2. It changes. Sorry, I'm changing our Arabic. You just change it to any room you want, and then it's a plug and play. In that sense. Okay. Now, I need your input for the configuration. Shall I keep it like this? This is the worst case scenario, meaning if today I don't have NMT is taken out. I don't have BIS, it will be no BIS. So how it looks like, look. So let me show you how and maybe the temperature also, you will not put the temperature all the time, so it will look like this.
It's important temperature. One of the vital signs should be.
Yeah. But I mean,
basic monitor.
Yeah, but I mean,
unfortunately.
That's why I would recommend get the esophageal. منه غالي صراحة. It's very yeah.
Why you did not include here?
I'm not the one who picks it, my
Because our boy request the machine, not request esophageal.
This is the new machine, new model. This one.
Sorry.
It's the new models or our also.
It's the same. It's the same. New machine, same model.
MashaAllah.
Okay.
A9.
A9. So what I explained to you today here is you already have it over there, but unfortunately I think maybe none of my colleagues came and explained to you.
How many machines we have like this?
I think 5.
Two.
Only 2?
This one.
No,
This
3
monitor.
here.
No, with monitor we have 3.
monitor and those
Asa
We have cat lab. Cat lab.
Cat lab.
Yeah.
Here in our.
In OR only
How
2.
many?
Two.
Two.
Yeah, in room.
Yeah,
four.
But A9 we have total here 4.
Ay, grabe.
That depends only the monitor. The other one there is no included in the monitor.
الليفل بتاع الساعه بتاع الاموج مطلع زي تحت
فين؟
في الكونتكست ده
Yeah, they need that one there for the BIS.
فلك الاموج لازم يكون في واحد من ده تحت فعندك
وفي
اثنين.
عندك تحت.
So your layout will look like this. Is it good?
It's good. Yeah.
You have it here. You have this. Not always. Let's say today you don't have CVP. You will not have CVP on every patient.
Even our arterial line.
عادي ما تكبرها. توضغط.
Yes. So for example, I will turn this off and all the pressures. So for example, like this. This is how.
سيبني بقى.
Alarm set.
No, the screen center here. But usually, I will tell you something. When I configure it for your doctor, you don't need to play around with it. Why? Because you put CVP, it will show you. You put arterial, no arterial light, this will go away. So let me take this out for you. The PA and all the measurements of the pressures. So let me take out all the pressures.
سبب البريشر والساتوريشن
And أهم شيء هو
بالنسبة للريت
it will not show. It will not show.
لو احتاجنا يبقى
So look, this is your basic.
اوكي بس حلو زي
This is your basic. One thing extra you will see is this is turning into red, and then you have a timer right here. When you put NMT will show here. You put BIS will come into this. How you start the timer? Start here, and I really encourage you use two different timers. Maybe I would say. You see, you have a timer here, timer there. One for the case, one for the neuromuscular, as you like. In that sense.
The pulse oximeter you have the for pediatric or
This
neonate?
one, only one. No pediatric.
We have pediatric. Ask how it is configured.
Okay.
There is pediatric, but right now we don't have this one. Only disposable.
Okay, give us some.
But we have extender. We need
a lot of pediatric cases.
no problem. We can provide you, doctor.
Even if not disposable, it's okay.
We don't have reusable.
We
Only
don't have-
We
disposable.
have also reusable if you want. So you can speak with.
You need to buy it.
It is same but small.
Small. Yeah.
Yeah. Or give us one box.
Yeah, we can give you, doctor.
Please.
I will ask in the Iskabu we have.
But you have to specify who is what I
Yeah, because there is neonatal and pediatric.
Yeah.
Also. Neonatal is very small and the only coming
Yes.
like plaster.
Yeah,
Like, not
we
like
have
this.
all
But
this.
for pediatric, I saw the small one. Maybe another company. or-
Another, but it's not compatible.
I will tell you, in Mindray we have everything.
Okay.
We have everything. You just need to.
Organizer request.
Two things.
Organizer request.
To be honest with you, two things. That's one you have to buy.
Yeah.
Second thing, I would say, our engineer, honestly speaking, maybe next time, these feedbacks, you can tell the engineer that, hey, listen, next time you buy this machine, make sure you have 1, 2, 3, 4, 5. You
Yes.
understand?
I understand.
And that things.
The problem, who requested this?
But we don't know this one.
Machine.
It's coming
Huh?
only.
So I don't know how the procurement.
No, actually, they buy bulk. They buy 96 units of Mindray A9.
Thank you very much.
They just provide.
Here we just not to be pessimist.
Yeah.
Arterial line technical we don't have.
Okay.
انت كده خليتها تخلع. That's one guy. انت خليتها تخلع مش عارف. This is the reality. What we have.
This is nice, but